aspects during this pandemic. The sexual reproductive health of populations is always in need of attention and of special programs because it represents complex aspects of human health and well-being. And in crisis situations, whether that is a humanitarian crisis or a pandemic, such as the one that we are witnessing with COVID-19, sexual reproductive health rights are impacted in various ways. And our webinar is going to actually highlight a lot of these impacts and different aspects of sexual reproductive health. There are already reports from different parts of the world, even from the Arab region, about heightened vulnerabilities, about accented gender inequalities that actually leave the needs of the most marginalized parts of the population, such as adolescent girls, women, migrants, and refugees unanswered. So as COVID-19 continues to spread across the globe, we expect sexual reproductive health situation to also worsen, especially in low and middle income countries, and especially if we don't build an in-depth understanding of the consequences of the short and the long-term measures to control the pandemic, and we don't develop timely responses and maintain these plans for the foreseeable future. So governments are continuing to focus their efforts on addressing the COVID-19 outbreak and dealing with the overstretched and overwhelmed health systems. We know that the sexual reproductive health and rights of populations, especially of women and adolescent girls, are disproportionately affected by the crisis, including disrupted access to healthcare services, such as life-saving interventions in maternal health, decrease in facility-based births in a lot of settings, increased hunger and poverty, particularly within the informal sector, which is mainly populated by women and migrants and refugees. Also interruptions in the supply of chain of contraceptives and what is called the shadow pandemic, which is the domestic and gender-based violence. And as the short-term measures to control the pandemic are loosened little by little in our region, the long-term consequences of sexual reproductive health will become clearer to all of us. So with this background, I would like to introduce our speakers today. We have with us Dr. Ali Kubba, who is a consultant gynecologist and senior lecturer at King's College London, and Dr. Shible Sahbani, who is a reproductive health advisor at the UNFPA Arab States Regional Office. Welcome both. We're going to start with Dr. Ali Kubba's intervention and presentation. He's going to talk about clinical aspects of sexual reproductive health and link it to global situation during this pandemic. The floor is yours, Dr. Kubba.
Thank you very much. Just share the screen. Excellent. Well, thank you very much, Tamar, for that introduction, and my thanks to my good friend Salman Rawaf, Professor Rawaf, for inviting me to take part in this, to me, very important meeting. It's a great honor to be here. I'm a clinician, so I'm a gynecologist and a specialist in sexual reproductive health. I use a lot of images in my slides, so excuse that. This is Big Ben. I work in London, and I'm going to in a lot of what I say, I'm going to just reflect the challenges that we've had here, which actually can be quite easily replicated across the world and definitely in the Arab world. The other reason is the hospital where I work with, the St. Thomas's Hospital, is at the end of this bridge called Westminster Bridge. So we're very close to the seat of power, and this is why our Prime Minister, when he had COVID, just drove across and went to the hospital. This is a nice painting that I really like. This is Rifat Shakir Hassan, who's one of the great Iraqi painters, and this is a painting called Bustan al-Ma'rifa. It sold in London about 2 years or 3 years ago for over £250,000. And I think, you know, we are in the presence of the public health experts of the MENA region, and you are, in a way, the fountain of knowledge as far as COVID is concerned. I think the pandemic brought us a focus on a number of things. And again, the image here is an image about maternal health, in the sense it is a baby and there's a man somewhere in the background. It's actually a painting of a cousin of mine called Kubba, who's based in South Beirut. So for Beirutis, you might know where her gallery is. And I thought it is a nice thing, keeping it in the family, as we say. I think the pandemic brought a focus on a number of things: relationships, people being locked down together, healthy sexuality, enjoying your sexuality in a positive way, and highlighting that sex is part of our life, and we therefore have to make choices about that. I think it also highlighted the needs of the young versus the needs of the old population, especially in relation to how they interact with COVID. I think it highlighted to us that we should not take our health for granted, and therefore we have to look after ourselves. And I think there is quite a lot of education needing to be done in that, which I say taking charge, learning to self-manage physical and, very important, mental health. And it also highlighted that contraception is an important choice when the times are uncertain. If I am a family, I'm the head of the family, I've got 3 children, it may be time to actually delay the next pregnancy and use contraception, because we are not very sure how this pandemic is going to sort of behave and eventually, hopefully, be overcome. And therefore, Tamar has already mentioned issues around gender equality and looking after women. And I say, you look after the women and they will look after our society. And in this, there are a number of slides. They're meant to be partly sort of fun, really. I think for the young, I think it's very important for educational as well as employment opportunities for improving the status of women and beating poverty, which tends to affect women much, much more than it does men. And these are graduates from one of the colleges in Iraq saying مصيرنا بعد التخرج, and they're wearing these kitchen. This is the neighborhood where you don't want to be, because it is definitely not gender equal. We are all equal. I thought I'll show you this photograph. This is a supermarket, and you can see this is in COVID. There are signs on the ground to tell people how to go, and they have to be distanced. We've got a circle here. This is Theresa May. This is the ex-Prime Minister of the UK. And you can see that she's there with her bag, waiting to go into the supermarket to get her vegetable or meat or whatever. And what applies to every one of us applies to also people in power. This is another painting from Kubba, which she did in Iraq during the early days of the conflict. And this is, the title is Women on the Move. These are women who are being displaced from where they are living, and their needs are very important. The comorbidities they suffer from, nutrition, access to public health facilities, access to medical health, are very important. And the last is again from what is called Shara al-Mutanabbi in Baghdad, and it shows the importance of looking after the older generation. They matter. They are very important for us to look after. These are my introduction slides. So I now will declare an interest, and I thought we'll put to you the 3 items in my agenda. I'm going to show a slide on why do women do better as far as COVID. I'm going to look at pregnancy from a clinical point of view. I'm going to go quickly along these slides because of the time. And I'm going to look at services for women now and in the future. Meanwhile, I think it would be nice to show something that salutes the healthcare heroes that have looked after us and continue to look after us in these uncertain times. So why do women do better? Well, the simple answer is because they are clever. They're more clever than men. And so you can see that while men can only focus on one item, women can multitask. They can do a number of things at the same time. Remember Shahrazad and Shahriyar and how that story went. And of course, women especially during this lockdown, have been multitasking, looking after children, looking after their husbands and partners. Here we're having a haircut at home. So it's very important to understand the sort of the role of women in society and the role of women in leadership. This is my slide on where women lead. The virus recedes, and showing 3 countries, Denmark, Germany, and New Zealand. So more seriously, why do women do better with COVID? We know that they have a 30% lower chance of infection, and they get less severe disease. I think we can look at 2 aspects, behavioral and biological. Behavioral, well, women probably are more at home, definitely in the MENA region. They are less risk-taking than men. They are less impulsive than men. They smoke probably less. They don't drink. And obesity affects men probably more than it does women. And therefore, they may be at a, from a health point of view, at a better sort of position. They're more reserved, they fear stigma more than the males, and therefore they probably follow instructions better. They look after their family better. And maybe they're more likely to wash because they're a lot of them in the home, they have opportunities to wash. There are biological aspects to this which are very interesting, which are being looked at, and I'm the vice president of the European Society of Contraception. We are looking actually at hormones and immunity and COVID, and we'll be publishing a paper very soon in the European Journal. So estrogen, we know, enhances epithelial, endothelial, and collagen function, and maybe it will keep the arteries in a better state, for instance. Estrogen and progesterone have anti-inflammatory features, and maybe that is contributing to the better outcome. Very important, this is the area that a lot of people are interested in, which is that estradiol modulates the ACE2 receptor. And as you know, the ACE2 receptor is the one that COVID gains access to the body for. And therefore, we think there may be an element of downregulation of the ACE2 receptor in women, which essentially means that the sort of viral load, the access of the virus, would be less. We know that androgens don't do as well. Baldness has been associated with a higher risk of COVID, and this is one of the explanations about men. So women also are better from that point of view. And of course, biologically, women tend to try to protect the children. By doing that, they protect themselves probably. But you have to be aware of the individual risk factors. So women who are at risk may still have a problem. This is a slide of an Iraqi family, and I usually show it to make 3 points in this slide. One is you need to know the instructions, the information. For instance, one thing that is not doesn't need to happen in this slide is this little boy doesn't need to wear a mask. In this country, children under the age of 11 are not necessarily needing to wear a mask. The second point is that you can see that there is this young lady who probably has physical disability. I don't know, maybe cystic fibrosis, maybe something to that effect. And she should be shielding. She should really be in the house being fed, giving her medicine without making contact with others. And the third point I'd make is this is a young family. I think both parents are probably in their 30s, and you can see they have 1, 2, 3, 4, 5, 6 children. And the idea that comes to mind with this family is they need contraception. I think it is very important to think about that. I'm going to quickly run through some slides about pregnancy and COVID. We know that the infection risk for pregnant women is similar to non-pregnant women, and it is less than men. The severity of the disease and risk of dying is no different from non-pregnant women, except in the 3rd trimester, where there is a higher risk of premature labor, intrauterine death in a small number of cases. There's no increase currently in miscarriage risk or congenital abnormalities. And as I was mentioning, risk factors associated with poor outcomes, diabetes, hypertension, COPD, and so on, obviously are associated with poorer outcome. Vertical transmission, which a lot of people are interested in, does happen, but happens rarely. And there does not seem to be a fetal effect from that currently. So we know that the placenta is negative for the virus. And in this big study, the UK OSS study, which is essentially the database that the Royal College of Obstetrics and Gynecology keeps. This is from about 3 months ago, so the cases are much more now. But in these, something like 2.5% of babies tested positive, and if the mother was COVID positive, then 5.6 would be positive. There was no increase in their need for neonatal intensive care. And 5 out of the 427 cases of COVID died, 5 of the women. So this is lower than the standard mortality that we see in this country. As I said, cesarean section is quite high. Breastfeeding, which is very important for women in the populations in MENA, we know that breast milk is negative for the virus, and therefore we encourage women to breastfeed. And she can actually still breastfeed, but wears a mask, and the baby will have a shield, or she can have the option of expressing the milk, sterilizing it, and giving it to the baby. Care for the pregnant woman in this country, and I think it should apply globally, is the number of antenatal visits are as the milestones. In this country, a woman has 6 antenatal visits during her pregnancy. We can definitely use home monitoring of blood pressure and glucose, doing urine tests. At term, we may consider testing. This will help decision-making if the woman, for instance, gets a postnatal infection, gets a fever, for instance, and it may be safer for the baby if she's very important, we're highlighting the option of post-placental contraception. So if a woman delivers, you can actually put an IUD or IUS, an intrauterine hormone-releasing system, or put an implant at the time, around the time of delivery, maybe even in the labor room itself, which is very important because it technically takes contraception out of the picture. And the evidence is that even if there are problems, for instance, with IUD expulsion, the outcome at 6 months shows that women who have post-placental contraception are more protected against unplanned pregnancies than others. And remind everybody about the neonatal vaccination. More babies die from preventable infections because they miss vaccination. Let's talk about gynecological services, where gynecological services, at least a quarter, can be managed remotely. This is for the safety of the staff and for managing capacity. But face-to-face consultations are important because they sometimes, with couples, will pick up the non-verbal communication, which are vital in sexual and reproductive health. Heavy menstrual bleeding, a common gynecological symptom, can be investigated outside the hospital. Blood tests can be done outside the hospital. Drug treatment can be sent to the patient. The same applies to contraceptives and hormone replacement. We say that we need to limit the resort to laparoscopy because it's an aerosol generating procedure. And therefore, we may need to use ultrasound rather than laparoscopy in diagnosing gynecological problems. But very important that gynecological emergencies are attended to. So acute abdomen, pelvic infection, remember, sexually transmitted infection testing can be done at home with a self-taken swab or with a urine sample. Early pregnancy bleeding, you have to have your hospital open for that. Any abnormal bleeding, such as persistent postcoital intermenstrual bleeding. I run one of the largest colposcopy services in the world at Guy's and St. Thomas's Hospital. And during the lockdown, technically all our clinics were catering to women with persistent postcoital intermenstrual bleeding, investigated them. We never shut the service. I'm going fast. So a patient's journey, probably something that I can staff keep social distancing. So I'm going to move to the next slide. This is our clinic, and you can see how spaced the waiting area is. This is the reception. So you can see here, there is like the football pitches where you have the penalty zone. And the patient will essentially stand here, talk to the receptionist. This is our clinic pre-COVID. This is our clinic post-COVID. Same chairs. We've put signs here saying you can't sit on these. You can sit on this chair, and that chair, and that chair. And that keeps social distancing. I think when you're looking at women in quarantine, remember a number of things. You need to educate the women to watch their weight and indeed their partners and their children, because if you're in one place and bored, eating, going to the fridge is a good, a bad habit, but it's something that is comforting. And as you know, that if you are obese, you probably have less protection if you get the COVID vaccine eventually, as we know that vaccines are less effective in those who are overweight. We need to inform women that if they have anxiety or depression, they need to ask for help, and there has to be a mental health facility available. And of course, being together is a good opportunity to know your partner, as I say, have a second honeymoon at home. The other more serious aspect is intimate partner violence. This is a poster from Iraq. It says Kafa Unfan. Beware of that. The calculation is about 30% of women are exposed to intimate partner violence, and you need to find a way to help the women. So designating what we call a numerical helpline is very important. And the idea with this, I'm just going to demonstrate it to you because it's one of the things that was put in place in the UK. So if you're with a partner who is abusing you and you want to call the services, you probably will not be able to speak on the phone and say, this partner is abusing me. So the idea is that whatever your emergency number, let's say it's 111, you tell the woman that if they ring 111 and then they press 123, the person who is receiving the call, because they know the code 123 or whatever other code, will know that code is from someone who is at risk, and therefore they may be able to offer help without the woman actually speaking a word on the phone. Tamar mentioned vulnerable groups, and I think it's very important to remember safeguarding for the young, and to remember those who are displaced, the refugee community, where facilities are poor and where the pandemic can spread very quickly. From a sexual reproductive health point of view, again, young people are vulnerable because they are in close proximity, and the protection of being in a home is no longer there. Looking at contraception, contraception is a matter of life and death. This is from the Lancet series looking at contraceptive prevalence. As it increases, the reduction in maternal mortality increases as well. And it is phenomenal. So if you go from 20 to 60% coverage in contraception, you're improving the maternal mortality rate by about 50%. You're cutting 1 in 2 deaths. So increased access means fewer maternal deaths. In looking at SRH services, we have to set a standard. In this country, we've declared that contraceptive care is a time-critical service and needs to be prioritized. Where there is abortion available, definitely available in Europe, abortion care is seen as an essential service to be continued. Our services for emergencies are open 24/7. If you have time-critical gynecology, as we've mentioned, you need to see them in a green environment. For instance, in our case, all high-grade cervical disease needing in a very safe green sort of bubble in a way. Remember, any woman who you get the impression is suffering from severe anxiety, you need to do something about it. You cannot ignore her, the fact that she doesn't have a physical problem. Never ignore. You may offer a remote consultation first and then decide whether you need to see her or not. This is what happened in the UK during the pandemic. So you can see there's January and there is July and there is again the pandemic time. And this is the use of emergency conception. It suddenly dropped when the pandemic arrived. And the reason is people, though they can buy emergency conception from a pharmacy, they were less likely to go to the pharmacy because they were worried about COVID. Pharmacies may not have stocks. It could be that obviously couples were having or women were having less sex and therefore taking less risks. We have in the UK a service called SH24, Sexual Health 24, which essentially is a telemedicine, telehealth service where someone can just go on the web and ask for pills, ask for STI testing. And you can see that what happened beyond February is that the dispatch of both the combined pill and, more importantly, the progesterone-only pill rose very high. And here we have the STI tests. And I want to just highlight the idea of the progesterone-only pill because it's a very safe contraceptive. It's available, people can get it. It has no medical risk, and therefore it is a good bridging method during these times. Contraceptive choices, we said emergency conception is over the counter. Pills can be sent by post or click and collect, be collected from a pharmacy without needing to see a health professional. Make sure that you know about contraindications, make sure that you assess the risk of pregnancy, and obviously people can have their blood pressure checked quite easily. And I've already talked about the progesterone-only pill. Remember that any method, this is what we call quick starting, and it's very important for people trying to sort of grapple with the issue of contraception. Any contraceptive method can be started at any time, as long as you're sure the patient is not pregnant, the woman is not pregnant. And if it's started, it becomes effective within 7 days. And that's an easy rule about giving someone the pill or putting an implant or other methods of contraception. I just wanted to highlight that there is some work going at the moment on what we call long COVID, because we know that there is this coagulopathy that happens. This is a paper which was published fairly recently showing a 20% risk of venous thromboembolism in women who are in hospital with COVID. It's something that we need to look at, and I'm not going to talk too long about it, but in COVID patients, take a contraceptive history, encourage mobilization, hydrate, and review contraceptive choices if clinically appropriate. If someone is on the combined pill, you might want to move her to a progesterone-only pill. With long-acting methods, we have, and we know that, for instance, the intrauterine device is common in the Arab world. Devices can be kept up to 12 years, so beyond their time. The same thing for implants, and the same thing for hormonal devices. I'm not going to spend too much on this technical aspect. One of the things that have happened during COVID is that for medical abortions, the woman could actually take all the tablets at home, and we're now talking about home abortions. This required a change of the law, which was done very quickly in this country. This is not the slide that you want to see, but I was just going to highlight that this is in the American Journal of Obstetrics and Gynecology, published last week. It essentially this is the Johns Hopkins ambulatory gynecology. If you access it, it gives you most of the information that I've just given you in this talk. So this is the detailed reference for the article. Last couple of slides. COVID safe sex. Sex happens, is part of our lives. We need to be comfortable to talk about sex. If you are comfortable, the patient sees you being relaxed, you as the healthcare provider, whether you're a doctor or a nurse, they can share their intimate thoughts. Do not judge your patient. Just tackle her problem or the couple's problem as such. And therefore, if you want to think about COVID safe sex, talk about positions. Talk about alternatives to penetrative sex. Wear a mask, and that could be actually fun as part of the Sex Act. And definitely, some people are thinking that a mask would be a good idea during orgasm because there is probably more aerosol production during that. But I'll leave that to your imagination. Obviously, no sex if you are ill, but there are other ways of giving empathy, pleasure, and love. For lonely adults, we now talk about Zoom dating, and at the moment, as universities have started Fresher Week, many universities are doing what they call Zoom dating or very rapid dating. Telephone sex, remember, use contraception, beware of intimate partner violence. And do not forget some of the themes I've just given you. I've put some images here. So services for young people. They have needs, we've identified them. It is important to talk to them about their health in general, and COVID gives you that perspective. We need services for working mothers. That is very important. We assume that the mother has to look after the baby. We need to have facilities, whether they're nurseries, sharing services for the working mother. I like this slide, though some people say it's a negative slide and the woman is holding a cigarette, but it's about loneliness of those who live on their own. In the Arab world, we have a lot of widows, a lot of people who are looking after families on their own without a man in the family, and there is a mental health dimension. Mental health is very important. I know that you've had one of their webinars on that. And relationship counseling is very important. And PPE, you can see here a mother and a baby coming together on the labor ward, but they are actually safely separated. And don't forget childhood immunization. So this very stern look on the baby is a message to us to make sure that we use vaccination. You have to look after yourself and your staff. This is my team. These are two nurses, working very hard during these times. I went and got them these Spanish chocolate cigars, which are fantastic. They can sort of use them for a while, pretend they're smoking, and then they can eat them. You need to keep in touch with your patients, and there are a number of facilities, and I think you've already discussed that previously. And you have to make sure that if you are running a remote consultation, that you have the principles of that, set up an appointment which is convenient, a secure platform, virtual consultations, validate the identity of the patient, where there is IPV, intimate partner violence, make sure that you agree some sort of a sign that the patient may say, oh, my partner is coming. Keep good records, and you can send leaflets and videos, and always do a report. I'm the Vice President and the Head of Education for the European Society of Contraception and Reproductive Health, and this is my advertorial, as they say. So I'd like to invite all of you to come to Ghent in Belgium. The beer is good, the chocolate is good, and it's one of the top cultural venues in Europe for our Congress, which will be in September 2021. These are the links. And I think, actually, this is an invitation for MENA, for WHO, for UNFPA to contribute to this Congress. We have a lot of Arab participants in these congresses, and indeed a lot of Arab delegates who come to the webinars we're running at the moment. So I'm hoping that we will have your contribution, and we'd love to definitely see you on board. So I think together everything is possible. So safe mother, important, family harmony, the man, the woman, the baby, and the dog. And this is Suad al-Attar. This is the great Suad al-Attar, the Iraqi painter. And I think, relationships are very important to be respected and nurtured and supported. Thank you very much for listening. And I apologize for taking a bit longer than I should have taken.
Thank you, Dr. Kubba. Thank you for bringing to our attention gender inequities and how the societal burden falls heavily on women. And also the important ongoing research on biological differences between sexes. So that's, you have the genetics, but also the social aspects. Also the high C-section rates, which are always an issue in our region, but it looks like we need to also highlight that and look at it and research it more closely during COVID. The promotion of breastfeeding and the importance of that despite COVID. So these are really important issues that we already suffered from in our region. So these are important to highlight from the clinical aspects of them. Also how we need to reorganize sexual reproductive health services and think of what we can bring more to women and their partners and their families through self-care and telemedicine and all other, forms of reaching women and their families during this pandemic. So based on this clinical background and these clinical aspects, we can probably move now into looking more at the impact of COVID-19 on different aspects of sexual reproductive health and looking at solutions that are being planned and implemented. And with that, I want to invite Dr. Shible Sahbani from the UNFPA Arab State Regional Office to guide us through his presentation. The floor is yours, Dr.
Thank you very much, Tamar. Let me try to share my screen. Okay. Okay, I think it's working now, right? Okay, perfect. Thank you very much, Tamar, and thank you very much, Professor Salman, for the invitation. It's very difficult to make my presentation after the excellent presentation of Dr. Ali, but I will try to do so. So I will try to address the issue of sexual and reproductive health during COVID time from a different perspective, from health system perspective, but also what can be done by the health system to address these issues. So my name is Shible Sahbani. I'm the reproductive health advisor with the United Nations Population Fund, and I'm working in the Arab States Regional Office, and we are covering 20 Arab countries. So let me start first with a quick introduction. We all know that the world faced many global pandemics over the history. And even during the last decades, the world has experienced many public health emergencies, be it Ebola, MERS, polio, cholera, including in our region, by the way. Also, our region, the Arab region, faces a lot of humanitarian crises, which leads to some epidemics, like the cholera in Yemen, like polio in certain countries in 2013, 2014, and so on. But all this has two common things. The first one, we learned that the health systems were not well prepared and were not resilient enough. The second common factor is that the demand on health services, including sexual and reproductive health, continued during emergencies. Not only the response to the epidemic itself, but also other needs, health needs like non-communicable diseases, mental health, sexual and reproductive health, and so on and so forth. So I will try to go through different components of sexual and reproductive health, or at least most of them, and to see what was the impact, or what would be the impact of COVID and public health emergencies on these components, and what can be done from a health system perspective. So regarding maternal health, as clearly mentioned by Dr. Ali, for now, there is no current clear evidence of direct adverse effects on pregnant women from COVID-19. It's unlike Zika or MERS or SARS that led to abortion or to prematurity or bad maternal health outcomes. However, pregnancy is a risk factor because there is a change in the immune system, in the hormonal system, and also in the physically. At the same time, safe pregnancies and childbirth depend on functioning health systems. And we all know that when we have a very weak health system, we have very bad maternal health outcomes. For instance, every day we have 500 maternal deaths, preventable maternal deaths in countries with weak health system. Now, if we take the previous outbreaks or pandemics, we can learn a lot of them. Let's take Ebola as an example. So during Ebola crisis in the western part of Africa, there was an increase by 18% of women attending, of women attending antenatal care, 22% decrease in postnatal care, and also 11% decrease in the number of women seeking to deliver at a healthcare facility. But this has resulted in very bad maternal health outcome, which is mainly the increase in maternal mortality and morbidity, but also an increase in stillbirth rate. So in the Arab region during the COVID, what we witnessed, and this is the feedback that we got from different stakeholders, including from our country offices in Arab states. First, many health facilities are closing, either private or public, and they are offering limited services. The second thing is that resources in general were diverted from sexual and reproductive health to other priorities, which are considered as priorities. For instance, the emergency rooms, the ICU units, and so on and so forth. This led to a decrease on the availability of sexual and reproductive health, including maternal health and other sexual and reproductive health services. So it's essential that the health services continue to provide maternal health services during emergencies. And here I'm talking mainly about emergency obstetric care, be it basic emergency obstetric care or comprehensive emergency obstetric care. Also, in addition to the availability of services, we have to make sure that we implement very good infection prevention and control measures to avoid any infections within the health center for pregnant women, but also for the staff who are providing maternal health services. In addition to that, it's very important to consider pregnant women as vulnerable population, such as persons with living with disabilities, persons living with HIV, and so on and so forth. And the last point, the last recommendation when it comes to maternal health is that the midwifery and the OBGYN workforce should be empowered and protected also, because they are at risk of getting infected by PPEs, and this will have a negative impact on the availability of quality services. In certain countries, like in Palestine, in Jordan, in certain countries, they found alternative solutions, like the provision of counseling remotely through mobile devices or using other IT technologies. We have so many good practices that can be documented and that we can learn from for any future pandemics or public health emergencies. That was regarding maternal health. Now, when it comes to family planning, first of all, we need to agree that family planning is a life-saving intervention. And this was agreed upon in 2019 in Athena meeting, where family planning was finally included in the MESP, in the minimum initial service package for reproductive health in emergencies, and it was considered as a life-saving intervention. Now, the reality is that, including in COVID, but in public health emergencies in general, there is a disruption of the normal delivery of sexual and reproductive health, including family planning services and information. This is from one side. From the other side, access to supplies, commodities, and the equipment was impacted by the movement and transport limitations of goods and supplies. On the other hand, this is regarding the provision of supplies and services, but on the from the demand side, also there was an increase in terms of demand for family planning services, because a lot of women and couples in general, they wanted to avoid or delay pregnancy and childbirth during crisis situation, including in COVID. So I think it's very important for policymakers and decision makers to consider family planning as one of the life-saving interventions and to prioritize it. The second thing is to ensure access to voluntary family planning services to prevent an unintended pregnancy that can lead to unsafe abortion. And as you know, most of the abortion in our region is unsafe abortion that can lead to maternal morbidity and mortality. And also make sure that modern short and long-acting contraceptives are available, affordable, and accessible to everyone, everywhere. And here I highlighted long-acting contraceptives because in many contexts, access regularly to family planning commodities and services is very limited. So that's why we prefer the long-acting contraceptives, reversible contraceptives, of course. In certain countries, one of the approach that was done for short method is the provision of 3-month period to avoid any unmet need. For instance, the woman or her husband or both of them, they can come to the facility, and instead of getting family planning methods for 1 month, they can get it for for 3 months if they cannot get long-acting reversible contraception. Now, of course, when we talk about family planning information services, it's very important to take into consideration the availability of commodities. So during the current crisis, the supply chain of contraceptives, among other SRH medicines and commodities, were disrupted. So this was due to two main things. The first one is because many contraceptives manufacturers were not back to full capacity after the COVID-19. And as you know, most of the Arab countries, they are not producing the family planning supplies and commodities, so they rely on the importation of these commodities. The second thing, because transport of goods and persons was very limited, so it was a big challenge to import these commodities and to ensure a proper supply chain. One of the solutions that was done and implemented in many countries is the public-private partnership, by mobilizing the private sector to step up to provide family planning services, but also to provide the supplies like sanitary items, medical equipment, and family planning supplies and commodities. And they think the emergency was considered as a good opportunity to strengthen this public-private partnership, not only in terms of supplies and commodities, but also in terms of service provision and information share. Okay, after the mental health and the family planning, there is the menstrual hygiene. And we found through different surveys and programs that menstrual hygiene was not considered as a priority, unfortunately. But the reality is that menstrual hygiene doesn't change during emergencies. And SRH commodities, including menstrual hygiene, as very central to women's health. And even it increases in certain conditions. This, if we take into consideration that 70% of the health and social workforce are female, so I think it's obvious that it's very, very important to ensure that these commodities and these supplies are available for all women at any time, including for the health workforce. Now, let me focus a little bit very quickly on the health workforce, because I think the health staff was the main component of the health system while responding to the COVID-19. So during the Ebola epidemic, we found that the frontline health workers were at a higher risk of infection. Now I'm based in Tunisia for a few months, and just recently, the numbers that were shared by Ministry of Health regarding the doctors and midwives and nurses who got infected by COVID is very, very high, and it's even alarming. Not only those who got infected, but also those who died by COVID-19. And I think this is the case in many countries over the region. In the Ebola pandemic in West Africa, I'm referring to the Ebola epidemic, sorry, because I think that there are so many lessons learned from that epidemic that we can learn from to respond to COVID-19 and to prepare ourselves for the future. So many health workers died, and the health systems that were already weak, they got weakened even more due to the lack of qualified human resources, and they had to rely on other human resources which were not necessarily qualified. In the Arab States region, we conducted a study in 2018-2019 that has shown that we have a big, huge gap in terms of midwives and OBGYNs in the region. This is even before the COVID. More than that, the density of nurses and midwives in most of the countries in the region is not improving. It's even going down. like in Egypt, in Morocco, in Somalia, and Sudan, and Syria. And let me show you quickly a chart that shows the ratio of OBGYN per 100,000 persons in 2018. This is from the study that we did in 2018. And it shows that in many countries like Somalia, Yemen, Sudan, I mean, the numbers, they are very, very, very low, even before the COVID-19 crisis. Now, if we take into consideration those who got infected, or even those who died from COVID-19, it will worsen the situation. So for the health staff, it's important first to make sure that the human resources and also the other resources like financial resources, logistics, and so on, dedicated to sexual and reproductive health, keep providing sexual and reproductive health and are not diverted to go to emergency rooms or ICU unit or the other infectious diseases departments. And also it's important to make sure that the health staff, they are well protected and they get the PPEs that are really needed for their protection. In addition to that, the front health workers are under a lot of strain, not only physically, but also mentally. So it's very important to ensure that they get the psychosocial support. We talked a lot about psychosocial support for pregnant women, for beneficiaries, and so on. But the health work, the health force, the reproductive health workforce is also in need of psychosocial support in many contexts. So I want just to highlight something before I conclude, is regarding the marginalized groups and the COVID-19 and public health emergencies that are even deepening their vulnerabilities. So it's very important that we tackle this issue by availing the data needed, disaggregated data by sex, by age, by legal and pregnancy status. It's very important to make sure that this will inform the decision making and inform the policy makers, and also to make sure that all discriminatory measures and everything that can lead to a stigma is well addressed. And also, it's very important, as you rightly said, Tamar, women and girls, they are considered as vulnerable groups, and we need to make sure that they can access the needed services in a timely manner. And as I said before, the availability of data can help in addressing these issues. So now my 3 or 4 key messages. The first one is that the health systems should be well prepared and should be more resilient to be able first to absorb the shock, and second, to be able to provide the needed services. The second thing is that SRH services, they should be considered as life-saving services, and they should be prioritized during different phases, during preparedness, during the response, and during and after the response phase or the recovery phase. The third thing is that the surveillance and the response system must collect disaggregated data by sex, age, and so on and so forth to make sure that the decision makers, they can take the right decision at the right time. And the last thing, I think that every emergency has, we can learn from it in different manners. But in addition to that, we should promote South-South collaboration and to learn from each other, not only in terms of information sharing, but also we can share more than that. We can share the technical expertise. We can share even the human resources and the commodities whenever it's needed. And you remember what happened in Europe with Italy when they were seeking support from neighboring countries. So I think that strengthen the South-South collaboration and the cooperation between the Arab countries can help in addressing this kind of issues. And thank you very much.
Thank you, Dr. Sahbani. That was actually a wonderful overview of how the disruption in the essential services for sexual reproductive health, actually the evidence behind how it might lead to detrimental impacts in health outcomes. And that is really important to keep in mind while we are navigating through the different phases of the pandemic. But also the challenges to maintain these services. And I think you mentioned a number of initiatives or good practices and lessons learned, and the importance of documenting these good practices in our region, because their success is very much related to or factored into the contextual aspects of the implementation and its implementation challenges. Therefore, the importance and our role as a community to document these good practices and to actually be supportive in providing even evaluation, so that we really know, the lessons learned and feed into the preparedness schemes and plans that you were talking about. So I think there is a lot here to think about, to reflect on, based on the two presentations that we had. And I thank you again to our speakers. And I think I'm looking forward myself to the questions by the audience, and I'm gonna hand over to our panelists, Professor Khoja and Professor Rawaf. And thank you again for the invitation extended to me.
Thank you very much indeed, Tamar, Ali, Shible. It's really very enjoyable listening to the three of you. You tackled an important subject, which is of concern to many people during this emergency. This emergency is different than Ebola, different than MERS, different than many things. The dimension of it, Shible, is totally different. And we have a lot of questions, but let me welcome there is not. Anyway, Ali, I know you are leaving soon, Dr. Ali, and thank you very much. I know you have a big commitment. One of the questions that some of the contraceptive require intervention, i.e. face-to-face contact with the patient. We have seen across many countries, including the UK, those who require surgical intervention or face-to-face intervention, not virtual, they must have a test first, the PCR. And some of them actually required to isolate for 2 weeks before the appointment. Is that applied to women who need intrauterine contraceptive, for example?
Well, the quick solution, thank you very much. And I wanted to also greet Tawfik, who's just joined us. Very good to see you, Tawfik.
Thank you so much.
Okay, so I think the solution, there are two things. If you think about short-acting reversible contraceptives, pill, condoms, various versions of it, and including the injectable. Injectable, we now have a subcutaneous injection called Cyana Press, which the woman can watch a video. Is fairly easy to actually use. It's like giving yourself an insulin injection. So these can all be done remotely, can be checked through a telemedicine platform and should be all right. As far as long-acting reversible methods, i.e. IUDs and implants, obviously with an IUD, you're close to the sort of genital area, including the rectum. And the feeling is that you do need to use PPE when you do this, because we know that there is shedding of the virus through the bowel. That is important. Second is, if you're putting an implant, you're quite close to the woman herself. So you must wear a shield, and the woman herself would probably need to wear a shield as well. However, there is a solution. So during lockdown, we did not do a lot of changing of methods or insertion of devices. People who have an IUD can, and they think, well, I need to change it, can use it for another 2 years without a break in contraception. If they're worried, you can give them the progesterone-only pill as a bridging method. People using the implant can keep the implant for 5 years, definitely for 4 years. Again, if they're worried, you can give them a bridging method. People using the intrauterine system, the hormone-releasing system called Mirena, can use it for an extra year. So we have a bit of leeway. I think one of the areas which are important is emergency IUD fittings, for instance, for women who've had unprotected sex, and these have to continue. And we don't actually insist on testing them, and because they are by definition emergencies, and on them self-isolating. So we will take all the precautions. We actually deal with them the way you are working in theater doing an operation. And that allows these interventions to happen. But I agree with you, it is a bit of a challenge. And we think, women have suffered from not having access to services, not because of their fault, not because of the system not being able to provide it, but because of the complexities of COVID. When we have a quick test, a very fast test, we should be on a much better grounds.
I mean, before we go to Professor Khoja, and I welcome him again, the question is that during the lockdown, most probably, I mean, this is not theoretical, but this is a definite situation, that we have a lot of unwanted pregnancies. And women don't have access to a range of services because of the difficulties encountered, services closed. Why the primary care didn't play its role in meeting the needs of these women? I mean, this is a question to Shible, Tamar, and you, Ali. Shible?
Salman, can I've got a meeting which is has just started. So can I answer your question? And I'm sorry, I really love to be with you for the rest of the meeting. But I'm chairing scientific committee of the European Society. So I think the problem with primary care is that the women themselves had anxieties about going to primary care because they thought they will catch COVID. So they need to be assured. I think the primary care, possibly in some countries where remote consultations are available, really played the remote consultations more than they should do, even including my GP. When I went to my GP, you can't get into the surgery. You have to go through a sort of like a microphone to talk to them. So I think we probably overdid that. But the important thing is to maintain the community services. It really is important. I mean, Shible made the point about the fact that community workers can actually facilitate for women to access services, can reassure them, can provide them with short-acting methods, bridging methods, and can plan their care. And I think that is quite important. I've got to go, unfortunately.
No, don't worry. Thank you very much, Ali.
I really am honored to have been part of this, and I hope we'll see you in the future and see you maybe in one of our webinars for the European side. Thank you very much.
Salam. Thank you very much.
The UNPF and your experience across all Arab countries.
Yeah, thank you, Dr. Salman. You were breaking the last few seconds, but I understand that. I will just complement what was said by Dr. Ali. Yes, when it comes to family planning and met need, it's already an issue in our region, even before the COVID-19. But now with the COVID-19, the situation has worsened. Let me say that we need to differentiate between two. We have those who want to avoid pregnancy, but they cannot access services, and we have those who used to use family planning methods, but due to COVID, there was an interruption of the family planning method. For the first category, I think it was discussed in many countries and so on, and there were different approaches, but the idea was that they need to meet with any healthcare provider, and they cannot go and get the family planning methods without any contact with healthcare provider. Now, for the second category, those who used to get, for instance, pills or condoms and so on, so there were different approaches, either through the health community workers, so they can provide directly door to door, or they were like kind of partnership with certain INGOs or even with pharmacies in certain countries where they can go and get the commodities, and then there is a system of reimbursement or system of recovering the cost of family planning methods. But again, as I said before, it's very important that in such conditions to go as much as possible for long-acting reversible contraceptives, like IUDs, like implant, like in certain cases, injectables can be a solution. The second solution is the self-care. The self-care, like the Cyanopress, can be a solution, but to be honest, in our region, it doesn't work a lot due to the, I don't know how to say it in a diplomatic way, but like health illiteracy. We don't have a population that can do the self-care in a proper way if they don't get the proper information and the proper education in advance. So there are different approaches. Of course, the context in UK is completely different than most of the countries in our region, and we have to adapt to the context. Of course, also when we talk about GCC countries is different than when we talk about Maghreb countries or about Sudan and Somalia. So it's a case by case. Over to you.
Tamar?
Yes, I agree with these points. And I think that brings us also to think about how much the sexual reproductive health services are integrated into the primary healthcare systems. And the variability that we have across different Arab countries is also very interesting. And I think this pandemic has also been an eye-opener for us to see how essential services, which SRH is, essential part of, need to be accessible through other services. And probably now we need to think of how to integrate them into COVID services. So it's really challenging, especially when we're talking about health systems that are functioning in fragile situations and they are overstretched and overwhelmed. But I also want to probably continue the idea that Dr. Sahbani talked about the workforce. And at the beginning, at least at the beginning of the pandemic, the workforce were not well prepared. At least I'm talking about the sexual reproductive health workforce in our region, in many countries. And the disruption happened very sharply. And it took some months for actually the workforce to kind of start to reorganize itself into a functional workforce that can actually be on top of the tasks that are required. And that is another lesson learned for us in the region, to actually have the preparedness plans, for crisis preparedness plans embedded into our national approaches and national plans. I mean, we are a region, a lot of our countries in this region are really fragile and have been going from one crisis to the other, and we do not actually invest enough into SRH preparedness plans. And I think this is another lesson learned from the experience we have in this pandemic. Thank you.
Khoja?
Thank you so much, Professor Salman, Rawaf, for organizing such a very important webinar. Especially it is part of the sustainable developmental goals, and developmental goals as well as it's very crucial as an indicator. And really I appreciate the leadership of Dr. Tamara and the participation of two eminent colleagues, Dr. Shible and Dr. Ali. I missed part of this, very important, because I have difficulties in the internet and starting up my system. I'm in Medina Munawwara. I send in my regard to Prof. Salman, to everyone here. So regard from Medina Munawwara to all of you and to our audience. My question, thank you, Prof. Salman. My question, we agreed upon that it is critical that all women should have access to safe birth and a continuum of the antenatal and postnatal care including screening for according to the national standard and guidelines. But within the pandemic and social distance and isolation and so on and so forth, what are the most important screening tests we should apply to the women who are pregnant? I have been asked so many times, do I have to go 5-6 times to the hospitals? What sort of screening test I should apply to myself? This one. The second one, what is your advice about breastfeeding and COVID and any pandemic? And I have a third question regarding to the primary care. I'll start with the 2 questions. What are the 2 priority screening tests for pregnant women and postnatal? Postnatal as well, especially we have lockdown and social distancing and so on and so forth. Then the breastfeeding. So I'll keep this to you.
Tamar?
Oh, I have the difficult task now to answer clinical questions, but Dr. Kubba actually covered the breastfeeding evidence and the need for promoting breastfeeding during the pandemic and having measures that women can safely breastfeed whenever they want to breastfeed their infants. So this should not be discontinued, and we should also think about what kind of practices and policies facilities are endorsing during the pandemic, and probably keep track of and monitor, because we should invest a lot in promoting breastfeeding in our region, especially in births and facilities, and considering all the policies around breastfeeding or infant feeding in our countries. Postpartum, I would say contraception is one of the most important aspects. Sexual health is another. And for this, I think women need to be listened to. We need to have a good understanding, in-depth understanding of women's needs during the postpartum period in our region. This is a very under-researched area. I myself have done few studies on postpartum health 10 years ago, maybe in Lebanon, but it's globally an under-researched area. And I think it is very, very much needed in our region. Postpartum health is a good stepping stone to kind of look at the woman beyond pregnancy and childbirth, and try to build with her, this life course kind of approach of healthy sexual reproductive health status. And I think we still need to learn a lot. And I would go back to a lot of the things that we can build on the self-care approach for the postpartum period. Building, Dr. Shible, he was talking about self-care, and I think health literacy is important to build in our region. And if we look at what women need specifically in that time period, mental health, sexual health, breastfeeding support, and contraception. These would be the headlines that we learn from research. But I can also, listen to others' feedback on this issue.
Dr. Shible?
Yeah, thank you very much. And very pleased to see Dr. Khoja. أهلا وسهلا من زمان.
الله يحفظك. شكرا جزيلا.
الله
هاي بركات دكتور سلمان. This is the blessing of Professor Salman Rawaf.
شكرا دكتور سلمان, ودعواتك من المدينة المنورة بروفيسور خوجة.
إن شاء الله. It is my honor. Thank you.
الله يخليك. So just to answer the question or to complement what was said by my friend Tamar, I think when it comes to maternal health, it's very important to ensure that emergency obstetric care is available, including, emergency obstetric care, but also antenatal care and postnatal care. Now, what's the best way to do that? The first thing, we already discussed the human resources. It's very important to ensure that the available human resources stay in the emergency obstetric care services and are not diverted to go to deal with the COVID-19. The second thing is very important to protect them from any infection. So to get the PPEs, all service providers should be protected so we can make sure that they can work in safe environments and they don't get sick and they don't leave their positions. The third thing is regarding protection of women themselves. In many of the clinics, we found that there is no clear path for pregnant women coming for antenatal care, for delivery services, or even for postnatal care. So it's very important to separate the COVID-19 pregnant woman from the other who are seeking services to avoid any new infections. So I think those are the three main pillars regarding the provision of emergency obstetric care. Now, in certain contexts, again, community health workers, they can help a lot in terms of antenatal care and postnatal care by doing home visits, but of course with taking all the precautions in terms of IPC, infection prevention and control, and also in doing sensitization. For instance, in Oman, they developed the system of having remote consultations when it comes to antenatal care. But at the same time, they did kind of education system to identify the danger signs. So whenever there is a kind of bleeding, there is hypertension, there is any kind of these signs, they can go directly to the health facility. Over to you.
I have.
Carry on, Prof.
Thank you so much, Prof. Salman, because Dr. Shible, he highlighted to some extent a little bit on my third question. You know, when I was responsible for primary healthcare in the Kingdom of Saudi Arabia, we always try to educate our healthcare workers in the primary healthcare about the high-risk group in pregnancy, during pregnancy, and to have a checklist and to have a special care for them. Now in pandemic, do you think it is wise to have the high-risk group of pregnant lady, like the people who has bleeding, or they have hypertensive, diabetics, heart problem, and so on and so forth, anemia, and so on? It's around 35 names of diseases for high-risk pregnancy. So during pandemic, is it wise to keep this pregnant lady within the primary healthcare setup management? Or what is your advice? Because you see, if they see the GCC, they have a very strong, and for example, Jordan, Tunisia, Egypt, they have a very strong primary health care, and they keep the pregnant lady to have their antenatal care in the primary health care. But as I am a practitioner, I feel there is a danger in this area, that a high-risk group. How can we deal with high-risk group? Is it a primary healthcare setup or is it a hospital setup?
Yeah, thank you very much for this question, Professor Khoja. Actually, it's one of the things that we discussed many times. But again, we don't have one size fits all. I would say that in context, like in let's say where we have less rural areas or less people living in rural areas, like in GCC countries where you have a lot of resources and also the equipment to transfer any patients at any time, you can rely on the secondary healthcare. But in context, for instance, if I take my country, Morocco, where you have remote areas in the mountains and so on, you cannot rely on the secondary healthcare. Because it's not available, first, in everywhere, and the second thing, you need to ensure that the capacity of the hospitals is not overstretched. Let me explain. You have let's say 1,000 pregnant women. Half of them are at risk. You have two possibilities: either to refer them to the primary healthcare, where they can be managed and monitored, and they are referred to the hospital just in case of need of comprehensive emergency obstetric care, or if there is any complication. Or the second option is to refer all of them to the secondary level hospital, where they will manage the antenatal care and postnatal care with very limited resources. So I think this is not doable in, I would say, 80% of the countries. except the GCC countries and maybe some of the countries that you kindly mentioned. So just in summary, if I have to talk about the Arab region, the primary healthcare is still the basis of our health system, and pregnant women should be monitored at the primary healthcare.
Thank you. Dr. Tamara and Professor Salman, I would like to...
I'll come to this point. I mean, Shible, this is an important point. I'll come to Tamara. We need to be careful in terms of emergencies, because primary care, I mean, all of us are part of primary care at some time in our life, is actually not well prepared to cope with emergencies, especially things like bleeding, things like, ectopic, etc. Remote areas, there is issues of geography, there is issue of time, but we need to structure and organize our system to services. Tamar, Lebanon is not a remote area.
Dr. Salman, you're cutting off. I'm not being able to hear you well.
Professor Salman, we cannot hear you.
When I was saying that, I don't know why. Let me change my internet. Can you hear me now?
Yeah, beautiful.
Okay. No, what I was saying that these emergencies are really require attention above primary care. As I said, we all worked in primary care at one stage in our life, and primary care is not well prepared to deal with emergencies. Tamar.
Yeah, I agree. I think it's understaffed, and there is a lot of expectations on primary care, and it's very varied between one country and the other in terms of what it provides, specifically in our region. And I agree with that. So, when we think of preparedness plans, we need to also have a good understanding of our health system and what could be covered in the primary and what needs a secondary or tertiary level, and then referrals and access and all of that, which might be challenging in terms of emergencies like we have. I mean, we faced that, but the complete unpreparedness we were in was also responsible for the chaotic situation we created in the essential services of SRH at least at the beginning of the pandemic. We're trying to catch up now, trying to learn, trying to kind of come up with specific solutions and innovative ways of handling things. I just want to also bring to our attention the importance that something that this pandemic also taught us is that quality care, or actually we knew that, but it's highlighted more and more, that quality care is not only the technical side of providing care. It's also the experience of women with reproductive health services. And, there are anecdotal evidence globally, and we are looking into the Arab region for such evidence of, more mistreatment and more disrespect towards women while they are seeking care. And this will not encourage the population to access care whenever care is available. So, we are creating more and more challenges. And there are many reasons in the system for that. It's not that I'm blaming a group of people. It's just that, the system is overstretched, understaffed, the workforce is overworked, all of that. However, I think we need to find mechanisms to incorporate women's voices into the way we define our services, into the way we build and prepare our services in times of emergencies and beyond. And I think we should keep that in mind.
Yeah, I'm really want in the last 4 or 5 minutes of our webinar, I want to bring the issue of, and we have a question from Dr. Nadia, I think. Yeah, which is very relevant to what I'm going to raise about the workforce. I think we cannot provide good services with the picture you presented, Dr. Shible. It's a very important picture, very low number of obstetrician and gynecologists per head of population, 100,000 or 10,000 or 1,000, depend how people calculate it in different parts of the world. The second thing is the lack of the needed midwives. I know some Arab countries, even they don't have college or schools for midwifery, which is really, some of these countries are prominent countries without mentioning names, you know. But I think this is a serious issue. How can we provide service in normal circumstances with such shortages, let alone in pandemic like the COVID-19? Dr. Shible?
Yeah, I think, Dr. Salman, you said it all. As you said, currently, or even before the COVID-19, there was a big shortage in terms of OBGYNs, nurses, and midwives. And as you said, in certain countries like Egypt, there is even no school for midwives. And I think this is
that's very strange. That's very strange.
Exactly. Yeah. So we worked with some countries, like in Somalia, we established the first midwifery school, and now they have like 15 or 16 midwifery schools, for midwives in the different states. But still, the gap is huge. This is one thing. The second thing is that in many countries, we found that they have midwives which are not actually midwives. So those are like traditional birth attendants, which are called midwives, and this is a big issue in terms of the quality of care. And they are, in some cases, I'm sorry to say this, but they are even contributing to maternal death and maternal morbidity. Yes. So it's very important to address this issue. But due to this shortage, we have to be smart in the way we are investing in those who are not midwives, but they can play the role of community health workers. They can educate, they can help, they can distribute family planning methods, for instance. And this is very important. Now, if to respond to your question, how we can deal with this, I think it was already said. The first thing is that we need to invest on the existing human resources, enabling environment, secure and safe environment to work with protection and so on. And at the same time, invest in the future, opening new schools, opening new medical faculties or universities, but this is for the mid and long term. At the short term, we need to invest on what we have. The other thing, and you will be invited, all of your colleagues, for the next year, the big conference on the Arab diaspora living in abroad and their role in strengthening the health system in the Arab region. It will be under the leadership of the League of Arab States, but I think it will be very, very important because we have a lot of expertise abroad that can help in capacity building, that can help in strengthening the health system. And I think until now it was kind of ignored, and we didn't invest in that expertise in that diaspora. And it's something that maybe can bring new solutions in the midterm.
I mean, this is in the last 30 seconds. This is a huge inequality for women, honestly, and putting many families at disadvantage. At the end of, we have always, when we have pleasure, we don't have enough time. That's a reality of our webinars. Always we are enjoying ourselves and good participation. First, I apologize to all our colleagues who asked questions and we couldn't address it explicitly by names. Secondly, on behalf of members of the Arab Public Health Association, Professor Khoja and I would like Tamar to thank you very much indeed for your valuable time. Thanking Ali, who left for another meeting, and Shible, thank you very much from you and PF. I'm really, really grateful to you all. Next week, our session is on actually antimicrobial resistance and the use of antibiotic during COVID. We have Dr. Hanan from WHO, Dr. Suha from AUB, and chaired by a colleague from Jordan, Najwa. So I look really forward to see you next Wednesday. Good night, good morning, good afternoon for everyone. Bye-bye.
Thank you.
Thank you so much.
Thank you so much, Prof. Salman. مع السلامة دكتور شبل. مع السلامة دكتور تمار. الله bless you all. Thank you.